In terms of dealing with movement and movement function, how we correct problems in movement function has been an area of a lot of debate. One school of thought is about we need to do functional things to fix functional problems. And that's particularly the thinking in terms of strength conditioning and sport to a large extent. There's also a lot of work that's been done looking at affecting function that is pain related. And there's two schools of thought there too. Again, doing more functional things is more relevant to what people do, but does it change the problems? A lot of the research, particularly in the last 10 to 15 years, has shown that pain-related issues associated with injury or recurrence affect the way we move. Pain changes the way we move, and pain also changes the way the brain coordinates movement. So pain changes not just your movement function, but how the brain programs the movements you do. And so what we see nowadays is that in chronic and recurrent musculoskeletal pain, there are changes in how the central nervous system coordinates muscles to do functional movements. And they're pre-programmed in. They're programmed in as part of the way you move. So for example, there are timing delays in muscles like transversus abdominis. Muscles like vastus medialis oblique change their patterns of recruitment from a tonic continual activation in the background of knee movements to an on-off pattern. So there's changes in the way that we move in local muscles. There's also changes in the way we coordinate global stabilizers and global mobilizer muscles. In non-fatiguing functional activities, normally the global stabilizers are the dominant synergists for the amount of force required. It's low force, but the mobilizers don't work as hard as the stabilizers. And for high load function, the mobilizers and stabilizers all work harder, but the mobilizers do the lion's share because they're biomechanically and neurophysiologically advantaged for that. In the presence of chronic and recurrent pain, that changes. The brain loses the ability to discriminate so clearly in unloaded, non-fatiguing function, so the mobilizers are dominant all the time, and that's pre-programmed in. So by doing functional things only, we use what the brain programs us to do, the pattern that we currently have that is pain-linked. So there's a lot of research now that has shown that if we can change the way the brain works when we coordinate functional movements, we can change function. The trouble is, it's difficult to do that with a functional movement. We've got to, for the body to do something differently to what you are programmed to automatically do, we've got to consciously change what we do. And so that's where a lot of the work nowadays has shown with low threshold problems that are linked to pain, alignment, coordination, timing problems linked to pain, we've got to do cognitive activation. Usually cognitive activation using a non-functional strategy to change what we already do. We see that when we cognitively activate in non-functional strategies, we start to change over time the threshold of automatic recruitment of certain muscles. So for example, if we cognitively activate the transversus while we maintain breathing, we start to change its threshold, so the timing delay starts to correct. Other research by Sarah Mottram has shown that in scapular movements, if we cognitively control the scapular position while we lift and lower the arm, over a 10-week period of time, we change the automatic activation of serratus anterior and lower trapezius in normal arm lifting and lowering to match normal controls of people who have no pain. So there's now good evidence to show that in both the local and in the global systems, movement control, retraining, trying to control the uncontrolled movement, trying to change the thresholds of automatic activation requires a cognitive, often non-functional, skill-based training to change something you automatically do, to change the program the brain runs to do functional movements. Under high threshold training, there are similar issues involved, but in high threshold training, there is a lot more specificity for load, there is a lot more specificity for function. And so we find also the ability to control the uncontrolled movement. So under load, we see the back flexes or the shoulder drops downward or forward tilts. And again, teaching people to cognitively, under high threshold strength and speed training programs, to control or limit or prevent excessive downward rotation or forward tilt of the scapula, trying to limit or control or prevent excessive flexion of the back during resistive leg loading exercises, changes the way and changes the proportions of muscles. So we start to recruit the stabilizer muscles more effectively. If we, during high load activities, fatiguing or high alternating speed activities or stability challenges, create asymmetry in the system, The mobiliser muscles are biased for symmetrical, sagittal, bilateral loading. That's what they're good at. The sagittal plane is the plane we're most explosive in. If we create asymmetry, that challenges rotation. That creates a rotation challenge to the core, to the scapula and the shoulder girdle, to the pelvis and the lumbopelvic area in the hip. And by creating asymmetry, the muscles that control rotation, the global stabilisers, are required to upregulate and work more. The central nervous system has to increase the recruitment of global stabilisers and global stabiliser strength training if we create asymmetry to high load, high threshold, fatiguing, strength and speed training. And so long as we do that within the cognitive ability to control flexion if it's uncontrolled, to control rotation if it's uncontrolled, and creating asymmetrical challenges to the pelvic girdle and the shoulder girdle and to the core, we can also start to change the way we do normal function and we improve the strength of global stabilisers in core strengthening programs.